All right, we're good. Okay, so this is the case of Jamie, who's a 12-year-old student, goes to the local school, has had behavior problems for the last 3 years. Was originally diagnosed with bipolar disorder, NOS, which is not specified. After experiencing highly irritable mood for 8 days uh, for the last month, he was it was marked as a change of his normal behavior. He had a depressive episode in 2010 where they did diagnose him with major depressive disorder, single episode. Lately, his mood has been accompanied by restlessness and a decreased need for sleep. He was just recently diagnosed by his medical doctor, not a psychiatrist. She used the ICD-10 as the criteria. We do have the release of information in order for us to talk to the doctor. Says the symptoms are subthreshold, but he illustrates, or she, because Jamie could be a girl, illustrates bipolar spectrum. Was prescribed Divalproex, Clonidine, and Zoloft. Okay. The bipolar spectrum, as we understand it, is without manic or hypomanic episodes. So, question one is, where will we start with the client and his family and the top two things that should be done as it pertains to the case? And so for me, I feel like reassessing him. I instantly, a light bulb came on for me with all of the meds that this baby is on. He's 12 years old. And not to say that maybe sometimes it's not warranted, but just in the course of 8 days, a normal shift in behavior, and just over the course of 3 years, his behavior problems started. So to be on all of the medications, I think it needs to be reassessed. Uh, and I feel like his diagnosis also should be reassessed.
Yes, I think that we should definitely make a referral to a psychiatrist and get a second opinion on that.
Yeah. Um, and so uh, with tying into the medication, question number two talks about the black box warning. And as we understand the black box warning, it is uh, pretty much like a more intensive side effect chart as the FDA looks at the medication. So this can sometimes come with life-threatening adverse effects. And so because we know that, when the family asks, I think that we have to absolutely answer as delicately as possible, but not only answer delicately, but as honest as possible, to just let them know that this is a very serious medication, because it's just a clonidine that has a black box warning. And so it's very serious. You have to take it the way that it needs to be taken. And if you see any side effects, to instantly go to the nearest hospital, just to get checked out. Because if it's saying that life-threatening reactions could take place, I think that it needs to be taken seriously.
Definitely.
Yeah, earlier you mentioned talking to um, the parents and the family really empathetically, and I think that's huge.
Yeah.
Being really honest with them, but also not scaring them, and making sure that they feel empowered to and confident to help administer these medications if they are ones that Jamie continues to go on.
Yeah. So with that being said, of course, question number three is, what is it? What can be done at home? And where will we start then? Which is pretty much the same questions. And so that's in terms of how it is that the family can actually help the child. And Rachel, just like you just said, you know what I mean? It is a responsibility. He's 12, for the parents to make sure that his medication is being administered correctly, because that is extremely important. Don't want to take the wrong dose. Don't want to miss doses if you're not supposed to, that type of thing. And so even after, being reassessed, if medication is still a part of the solution or part of his treatment, then they would absolutely have to do that. Also, the other couple of things that I was thinking about too, because we're talking about behavior in the child and how it is that the parents need to adjust their lives, because that's what it is. It's an adjustment. So I think first they need to make sure that they are capable of actually dealing with the stress, because sometimes, the behaviors of children stresses you out. And so then you start to react instead of respond. And if something is wrong with them, due to it being behavioral or a diagnosis, then if you're stressed yourself, you're not going to give them the empathy that they need as a parent, because you're too busy focused on your irritation. And so I think self-care would absolutely be one of my suggestions to the family, that they need to make sure that they are okay. And then number two is that they need to make sure that that they instill and enforce boundaries, that the child has consequences, and that they actually set up those consequences and keep at them. Because when you have, conduct disorders, when you have behavior disorders, when you have bipolarism, all those different things, that the behavior is something that you actually have to look at. Boundaries are very important.
On that number 3, how you another thing for the parents, I would just say that it's important for them to be well informed about these particular diagnoses and how they interact with each other, so they can kind of know what to expect, and like you said, adjust, so that not only they're able to deal with the child, but also so they know how to respond to the child, to not become triggers for them. I actually know a family that has a child. He's a teenager. He's 16. That's diagnosed with both the disorders that they're talking about right here, and it can be detrimental whenever the family that the child is living with don't understand the significance of these disorders, or how they operate, or what symptoms come out of it according to what type of triggers they have. So just to be well informed, if they could, it would be really nice if the parents and the child could do like counseling together, so they can work on the issues together from a more systemic, with a more systemic approach. And even if there was other siblings, it would be really helpful.
Now that's awesome, because I had thought about that too, about the family sessions and coming together collectively as a family, because you actually need that to be a cohesive unit and like really, really just kind of learn how to adapt to one another, especially with something so serious. And I love how you just said too, to get education. Like that psychoeducation is so important. Like the 12-year-old, of course, you want to educate them as well, but the parents, because they are the caregivers, absolutely need to be educated. And so that was, so that was an awesome point. So it seems like with Jamie, we, know that we'll start with the reassessment that will come with the psychiatrist referring them to a psychiatrist, or communicating with the doctor if the referral has to come from the doctor, for the reassessment of diagnosis, as well as the reassessment of medication. Being empathetic and talking to the family about the side effects of the medications and the severity of the black box warning. but making sure that it comes with, you know, some comfort and some love. And then also suggesting family therapy in order for the families to be on one accord in terms of dealing with the child, making sure that they practice self-care, instilling and enforcing boundaries and consequences for behaviors. And so that's the way that we would treat Jamie. Anything else?
Well, I think that sounds good. I mean, you know, it's a really tricky case. It's a young kid.
Yeah, and that's the thing, because kids, you know, I get a little, you know, sensitive about it. That's why I'm just like, all this medicine for this kid is just like it's just, I don't like to see it. Not to say that it's not kids in this world that are on more medications than 3 medications, but it's just like, okay, you don't want them to be in a catatonic state. You know what I mean? Like, you want a kid to be able to be a kid. And once his system adjusts to that, then it's just pretty much like he will potentially be medicated for life. So, all right, gals. So we only have 1 minute and 25 seconds before the meeting shuts off.